Thank you for joining us for our webinar on the brain-gut crossroads, the link between abdominal pain, IBS, and eating disorders. Creative Healing for Youth in Pain, or CHIP, is an online nonprofit organization that empowers youth living with chronic pain to heal by altering the brain pain circuits through exposure to creative healing experiences, educational resources, and peer support. My name's Dr. Shelley Siegel. I specialize in treating adolescents and adults suffering with chronic pain and medical disorders. I have a private practice in Calabasas, and am on faculty at the David Geffen School of Medicine, and am in the Adult Department of Psychology in the Health and Behavior track. I began working with Dr. Zeltzer after my postdoctoral fellowship, when she was the director of the UCLA Pediatric Pain Program. I continue to collaborate with her and our multidisciplinary team at UCLA and CHIP with a deep commitment to the mind-body well-being. Before we begin, we have a slide that will give us some information and some housekeeping. Please note our webinar is being recorded. Please enter your questions in the Q&A section throughout the webinar. We also invite you to comment on questions within the Q&A section. Audience questions will be incorporated throughout the discussion. We cannot guarantee that every question will be included. Previous CHIP webinars are available on CHIP's YouTube channel. Please consider donating $25 to CHIP if you find our monthly webinars valuable. Closed captions are available. Go to the button toolbar, search for more, and click Show Caption. Our speaker today is Dr. Leslie Kaplan. She's a pediatrician specializing in adolescent and adult medicine. After receiving her medical degree from UCLA, she went on to a pediatric residency at Kaiser Permanente in an adolescent medicine fellowship at CHLA, Children's Hospital, Los Angeles. She's a certified eating disorder specialist and has been treating eating disorders patients in various settings for the past 25 plus years, including primary care teen clinics, college health clinics, and eating disorder treatment programs. She currently sees adolescents and young adults in her specialized private practice, providing medical care for eating disorders. So with that, I'd like to give a warm welcome to you, Dr. Kaplan.
Thank you.
And begin our discussion. I'm wondering, how did you get involved with eating disorders?
Thank you. First of all, thank you. And it's really such an honor and a pleasure to be here. So I have always been interested in the mind-body connection and in the influences of psychology, society, and biology on each other and on the disease process. And eating disorders really represent the perfect model of a biopsychosocial model of disease. So something I've just always been interested in.
Thank you. Can you explain these two disorders?
Sure.
The
So
IBS and the eating disorders?
Yeah. So irritable bowel syndrome is a common digestive disorder associated with symptoms of abdominal pain, bloating, bowel changes in bowel patterns like diarrhea or constipation or both. And yet there's no visible sign of disease or damage on the intestine. So when colonoscopies are done and tissue biopsies are taken, those all come out normal, and yet these symptoms persist. And it should not be confused with inflammatory bowel disease, or IBD. We're talking about IBS. IBD is very different. There are changes when you do biopsies and colonoscopies. You see identifiable changes, and it has very different medical implications. So we're not really talking about that today. We're talking about IBS. Eating disorders are serious mental health conditions characterized by unhealthy or harmful eating behaviors. And there's really a broad range of diagnoses here. I'll go through just sort of the big ones, I guess. There's binge eating disorder, which is eating in a discrete period of time, usually 2 hours or less, large amounts of food, much larger than a normal portion. And it's associated with a feeling of being out of control, not knowing if you're able to stop. So those are binge episodes, and binge eating disorder is characterized by frequent binge episodes. Bulimia nervosa is a condition where there is binge eating, and then followed by a compensatory behavior like purging. And purging can be anything from self-induced vomiting to laxative use to even excessive exercise, all as a way to compensate for a binge. And then there are restrictive eating disorders as well. And the main ones of those are anorexia nervosa, which is a willful restriction of food intake with the goal of thinness, leading to significant weight loss, low body mass index, BMI. It's also associated with an intense fear of gaining weight. Then there's ARFID, which is avoidant restrictive food intake disorder. And that can be thought of sort of like extreme picky eating. But it leads to, so it's a restriction of food intake, which can lead to medical complications like not growing appropriately, not falling off the growth curve for both weight and height. It can lead to nutritional deficiencies, and also can lead to some severe psychological consequences. So families, for example, can't go out to a restaurant because they know their child won't be able to find anything that they can eat. And importantly here, it's not motivated by a drive for thinness. It seems to be more rooted in a few other drivers. So either it's a disinterest in food altogether, just not interested in eating, and avoidance of food based on sensory issues like taste or smell or textures. A lot of times we see this with kids who are on the autism spectrum of diseases. Or it can be a major fear of eating based in a past traumatic episode, like choking episode or vomiting, diarrhea episode, that kind of thing. And there are a lot of other diagnoses, but these are the main diagnoses, but these are the main ones that we tend to talk about, especially in the DSM, the Diagnostic Statistical Manual of Disease.
I'm just curious, when you mentioned ARFID, I mean, does it have to be considered an eating disorder if people are picky eaters, or is
Well,
there?
I mean, yeah, it's a great question, and sometimes it's hard for parents and even providers to know, the difference. Picky eating is really a very normal, I would say, part of childhood, early childhood. It becomes problematic or qualifies for the ARFID diagnosis if people are falling off the growth curve. So it's really affecting their normal trajectory. So most kids who have picky eating, we say, as long as they're growing normally, we're not going to worry about it. Or as long as it's not, having a huge impact on your family dynamic, it doesn't really qualify for this diagnosis. But thank you for helping me qualify that, because you're right, picky eating is a very common thing in young children.
Right, and thank you for that. With our CHIP community, we speak about the mind-body connection. Can you speak more about this in relationship to eating disorders?
Sure. Yeah, I mean, the mind-body connection is huge in these disorders. And we tend to think of, um, sorry. Yeah, the mind-body connection is huge with these disorders, and um, both of them, um, are really driven by these connections. So in irritable bowel syndrome, there's dysregulation in the two-way communication system known as the brain gut axis. So what I mean by that is the brain and the gut communicate by several pathways back and forth. They kind of talk to each other. And these pathways include the nervous system, nerves, neurotransmitters, which are how nerves communicate with each other, hormones, inflammatory cell molecules or mediators, and even the bacteria or metabolites of bacteria in the gut. So this is like a bidirectional communication. Brain talks to gut, gut talks to brain. And in IBS, those pathways are very much altered. In eating disorders, the brain-gut communication is also altered, interestingly. And one good example of this is ghrelin, which is one of many appetite releasing hormones secreted by the gut, that provides feedback to the brain. So if someone has eaten sort of enough, the ghrelin gets activated and tells the brain, okay, we're full, we're good here, you don't have to eat anymore. And though that ghrelin levels are altered in eating disorders. Interestingly, in anorexia nervosa, the ghrelin, the fullness kind of communicator, is elevated. And in binge eating disorder, ghrelin is reduced. So that's a great example of that brain-gut communication. Another thing I like to talk about is interoception. So interoception is the body's ability to sense, interpret, and integrate internal body signals. So it's like when, colloquially we talk about listening to our body. That's interoception. And that's actually altered in both of these disorders as well. So in IBS, one of the, we think, correlates or even potential causes of IBS is a visceral hypersensitivity. So, in other words, when the gut stretches a little bit because of food or gas or whatever it is, it's sort of the interpretation to the brain is very heightened. So it's really experienced as severe pain. In eating disorders, specifically anorexia nervosa, interoception is actually muted. So there's a real disconnect with the body and the brain. There's almost like a numbness that I see. And this is confirmed by the research. And in my experience, the most severe patients with anorexia nervosa are often the ones that deny any symptoms. No, I'm fine. And sometimes later when they go back, oh yeah, I was really having a lot of bloating. I was really having, but it's almost like they're numb to it in the moment.
Wow. I mean, I'm thinking about, the psychological impact
Mm.
then of, and I may be jumping the gun a little, but I'm just going to say I'm wondering. I mean, this like treating chronic pain is a multidisciplinary approach, right, to treatment.
Hmm.
Can you speak to that a little bit? Like, how do you put a team together, or what do you do?
Sure, sure. Yeah, I mean, it is definitely a disorder that requires a multidisciplinary approach. So there always has to be a medical provider, hopefully one that understands eating disorders. There has to be a diet registered dietitian, a nutritionist. We prefer registered dietitians because they are certified and trained. And you want to look for somebody with eating disorder experience. And there always has to be a therapist. Now, for children, um, the recommendations over the last, I don't know, 50 years or so have really changed in terms of what that team looks like and how they interact with the patient. So for young children, we really recommend something called family-based treatment. And I can go into this in more detail if that is a question. And but family-based treatment basically essentially um, empowers parents to refeed their child, and the providers, the dietitian, the therapist, the you know the well, mainly those two are really interacting first and foremost with the parents so that they can coach them on how to do this, because nutrition is such a vital piece of this, and that's really been shown to um, help with not only a faster recovery from an eating disorder, but also a more sustained recovery. Um, Certainly, this is an anxiety disorder and under the umbrella of anxiety disorders. So therapy, talk therapy has to be part of it. But at least in the initial stages, it's really just about refeeding the child with an eating disorder.
So similar, let's say, to chronic pain, and we can get into, let's say, the abdominal pain and the IBS.
Yeah.
The parents are a big part of treating the child.
Mm-hmm. Mm-hmm. Has to be.
With adolescents as well, I would assume.
Yes. Yeah. Sorry, I
So
know it's a little bit loud. We're a busy pediatric office here, so you're going to hear some noise. I apologize, but just want to
that's
say
okay.
I don't know what you're hearing.
Not much.
Okay, good.
So, okay, so it's also integrative with the parents so that, especially with young children, it's really helping them as a family. Um, are there psychological impacts there has to be on the family as well? When you're dealing with chronic pain, everybody suffers,
So true.
your
So true.
support system. So I assume
So
it's the
true.
same kind of thing.
Absolutely. Yeah. It's a huge, yeah, has a huge impact on the families. They're really worried. And so just as much as the disease itself impacts the families, also the treatment has to include families for sure.
And at any age, I would assume.
That's true.
Adolescents, of course, too. Probably, is it more difficult um, treating an adolescent with an eating disorder
Then an adult,
than a younger child?
oh, then a younger child. Yes and no. In some ways, the structure, I mean, obviously, in adolescents are dealing with, you know, how to assert independence and separate from the families, and there are all these complicated dynamics going on. And what at least traditional family-based treatment tells us, or the research tells us about that, is that it's pa parents kind of have to reassert control over things that they didn't think they had to anymore. And so there are always maybe a little more battles. It's a little more natural for children to, younger children to fall into that structure. But nevertheless, it is, there are some that might argue that adolescents who are going through this really want their parents to take charge and help them. And on some level, sometimes it's very small little level, but sometimes it's bigger. But so going back to that protective kind of structure is what's needed for both. Yeah. And
Okay.
also with adolescents, sometimes you can get a little more buy-in than with young children. So there's a little more inherent reward for for recovering. So that sometimes makes it easier. But anyway,
Okay. Well, thank you for that.
sure.
Um, how common is it for somebody to have both an eating disorder and abdominal pain or IBS?
So there's really notable overlap between IBS and eating disorders in the research. Um, each condition potentially influences the development and the severity of the other. People with IBS have a higher prevalence of eating disorders compared to the general population. And similarly, the majority of patients with eating disorders meet criteria for IBS or IBS symptoms. Um, and so there's a significant comorbidity, as we say.
Okay. Can eating disorders lead to abdominal pain and IBS?
Yeah, so certainly eating disorders can cause IBS-like symptoms. I think in order to strictly qualify for IBS diagnosis, you can't really have a significant eating disorder, but um, definitely abdominal pain, bloating, diarrhea, constipation. We can see even, yeah, we can see with our patients. So in binge eating disorder and purging, there's a lot of abdominal discomfort. There can be acid reflux, changes in bowel habits like diarrhea, especially if laxatives are abused. But also when somebody has a very restrictive diet, the body will make changes to adapt to the lack of nutritional input, the lack of fuel. It rations energy. And the body says, okay, I have to keep this person alive in the moment. I'm going to keep their heart beating. I'm going to keep blood flow to their brain. But since I have this limited resource coming in, I'm going to make some adjustments. And the GI tract, as such, slows down a lot. The stomach empties more slowly. The motility of the gut is slowed down significantly throughout the intestines. There's bloating in the intestines as the motility slows down, because the bacteria is sitting longer for a long period of time and producing more gas. And there's constipation is very common. In fact, gastrointestinal symptoms like bloating and constipation are probably the most common symptoms I see in my patients. Um, and also important to know that even if an eating disorder doesn't cause an IBS, changes in eating, like inconsistent eating or eliminating certain foods like fiber, which we see a lot. A lot of our kids with ARFID don't eat vegetables at all. So that can worsen IBS and IBS symptoms.
Wow. Okay. Are there, like with chronic pain,
Mhm.
we see some common personality traits like perfectionism. And
Okay,
when we're,
I'm gonna answer that question because I'm sorry, I didn't mean to cut you off, but I
oh,
definitely want.
sorry.
Yeah, you can. Yeah, I just wanted to say something more about that
Sure, of course.
causation, if that's
Yeah,
okay. Um,
absolutely.
and people always want to know if um, their child's abdominal pain can be a cause of restrictive eating. And sometimes that is absolutely the case. And although it's hard to test for causation in research. When we do research, it's hard to say, oh, this definitely caused that. There is um, a lot of research that points to a temporal correlation. In other words, the timing that you have IBS or abdominal pain and then an eating disorder. Um, we see that in the research. So, and it makes sense because if somebody has abdominal pain or bowel changes after eating, um, and feels miserable, it makes sense that they might avoid eating or eating certain foods. We see this a lot with ARFID kids, those kids that are afraid to re-experience those gastrointestinal symptoms, and then their diet starts to shift and their diets become smaller and more narrowed and restricted to only certain kinds of foods. Um, Also notable is that sometimes the treatment for IBS involves um, eliminating what we call a low FODMAP foods. And those are
Yeah.
foods that are low in fermented, excuse me, poorly absorbed carbohydrates that can lead to diarrhea and bloating. So when someone goes in for IBS treatment, very often the recommendation is go on this low FODMAP diet. And it turns out it's very restrictive. It's like impossible to stick to. Um, and this is a really important point. And when someone is restricting really for any reason or become malnourished for any reason, undernourished, their brain changes. There are neurochemical, biologic, anatomical changes in the brain that can actually worsen anxiety and worsen obsessive thinking that goes along with maybe OCD type thinking. Um, so when you have worsening of abdominal symptoms, as I mentioned, like a slowed GI tract, and combine that with worsening anxiety and obsessive thinking, this is really fertile territory for a restrictive eating disorder. And so it's really a slippery slope. The more someone restricts, the easier it becomes to restrict. And here we go down this very slippery, dangerous path. So I just wanted to make sure this is really a two-way communication with symptoms of restrictive eating and abdominal. I mean, a two-way, goes both ways with restrictive eating and these abdominal symptoms. So I'm sorry to interrupt your previous question.
No, you didn't at all. I mean, that was really valuable information. Um, so I guess if it's okay, back to sort of common personality traits,
Yeah.
temperaments that you may see. It, are there some that
Yeah,
you are notable
yeah,
with eating disorders and those who end up with abdominal pain?
yeah. And Shelley, you've taught me that people with chronic pain often have certain characteristics like perfectionism. And we see that specifically also with patients with anorexia nervosa. So they tend to be perfectionistic. They tend to have low novelty seeking. They don't like to do new things. High harm avoidance. They don't like taking risks. Um, and like cognitive rigidity. And these are things that they're kind of born with. These are temperament traits or things that somebody is born with. They don't develop. I remember when I was working in the neonatal ICU, that the nurses would be able to identify, oh, this baby's temperament is like this baby's temperament is like this. So these are things from day one. I mean, I don't know if they were predicting eating disorders at that point, but you get my drift that these are really
Yeah.
consistent throughout life. Um, Bulimia nervosa, interesting, is interestingly is different though. They tend to be in some ways the opposite. So they're more impulsive. They like new things and risk taking. There does often tend to be a little more emotional dysregulation, high highs, low lows, that kind of thing. So yeah, there are some traits that we've found are exhibited in eating disorder patients.
Interesting. Are there, you mentioned like OCD and anxiety, that seems to be, um, you know, maybe common with people with eating disorders. Do you tend to see patients suffering with depression or other maybe disorders associated with eating disorders, and also obviously with chronic pain, IBS
Yeah,
often?
it's a great question. And the research is very clear about um, anxiety and depression worsen with malnutrition, as I mentioned before, and obsessive thinking. Those all worsen with undernutrition. But um, I also kind of think about most eating disorders will accept, exception of some cases of ARFID, but otherwise, most eating disorders are under the umbrella of anxiety disorders. And it's sort of like a coping mechanism for anxiety. Not a great one, but that's just so I tend to think most of my patients have some degree of anxiety. Um, and then there are those cases where it really is just depression at the root. So if somebody is really depressed and they lose their appetite a little bit. And so sometimes if you just treat the depression, those patients who may not even necessarily have a drive for thinness, for example, those patients can get better just by managing their depression.
Wonderful. I mean, that's good information. Can psychotherapy be carried out with somebody who's, let's say, malnourished?
It's such a great question. So strictly speaking, it's very hard to treat somebody who's really malnourished with our typical medications because they just don't work as well. And that's probably because they don't, they're not taking in enough of the substrates to help those medications work, like the chemicals that need to be there to make the the medicines work. And so if somebody's really malnourished, it's almost like you don't really, I mean, it's not going to be helpful to put them, for example, on Prozac. However, there are medications which have been shown to work very well at stimulating the appetite, especially in patients with ARFID. And those are the atypical antipsychotics, for example, like Zyprexa. So those are used more and more for patients who are undernourished as a way to sort of maybe jumpstart things, more so in ARFID than anorexia nervosa, but even in anorexia nervosa. And that all said, in reality, in clinical practice, if someone isn't super severe, I do sometimes start these medications because the idea being, that it can calm down a little bit of the anxiety once they start getting in more adequate nutrition. And the less anxious they become, the easier it is for them to eat. And so we kind of fold it into treatment if they're, once they've started kind of, if they're not super severe. If they're super severe, we just have to focus on getting them renourished first.
Nourishing them.
Hmm.
Obviously, before any therapy would start, is getting them to a place where
That's
their
right.
brain is more nourished.
Right.
Now, this is, you mentioned, let's say, Zyprexa or the atypical antipsychotics. Those are known to cause weight gain.
Mm.
So for, let's say, somebody who's anorexic, you said sometimes you use it for anorexics. How does, how's that received? Something that,
Yeah, and everybody's so savvy right now that you can just look anything up and see what the side effects are. Um, so right, a lot of times there's pushback and it's not easy, and um, but um, in some patients it's really affected their lives. They're in treatment programs or they're, cut out of the sports they love or whatever it is, then sometimes they are willing to. So we do use what we can,
right.
right?
Okay, understandable. There's a question from a participant here. How might schools, teachers, school psychologists support students who may have ARFID, especially when children have to eat lunch with especially when they have to eat lunch with other children?
Oh, it's such a good question. So, I guess I would answer that with family-based therapy or family-based treatment, I mean to say, in mind, which according to that model, lunches should be supervised. So for some
Interesting.
patients, that means kids, step out of school and have lunch in the car with a parent or a caregiver, or in some cases, they go to a teacher's office. Some adult who's making sure that they're completing their meal. Um, Listen, I've heard it all. It's social suicide. It's what, kids do not like that one. But um, if I mean, the family-based treatment is really a way for the kids to be able to go to school and be able to, engage in other aspects of their life. So this seems like sometimes just one of the necessary steps to allow them to get back to their regular life, to get recovered or recovered enough and get back to their regular life. ARFID is a little trickier because it's often not something that, I mean, sometimes it stays with them, patients their whole lives. But if they can get into good routines, um, that's a goal too, to prevent those relapses of undernutrition.
Hey, thank you to our participant, and I encourage more questions from the
Mhm.
audience. Please feel free. Um, what should a parent do if they suspect their child has an eating disorder? And like,
Okay,
what are
so
some
yeah,
signs as well? Just sort of.
yeah. So so signs that you might see are things like meal skipping. Oh, I already ate with my friends, or just no explanation at all. They're just not eating. Obviously, that's a red flag if it happens frequently. Rigid food rules, cutting out whole groups of foods like carbohydrates or, fatty foods or fast food, just cutting everything out altogether. Or even things like if you notice that um, kids are um, won't let their food groups touch or are cutting food into very small pieces. These are behaviors sometimes we see, excuse me, Mm. we see with anorexia patients. Um, if there's a disappearance of food from the pantry that's sort of unexplainable, if there are bathroom trips after every meal, a preoccupation with weight, body size, certainly weight loss. Teenagers, especially young teenagers, should not be losing weight. They're supposed to be gaining weight. So even staying the same weight in a 13, 14-year-old is um, a bit of a red flag. These are all reasons that at least maybe should give you pause. These are things that you, if you see, you should, as a parent, be alerted to, and maybe check in. The first step should be a check-in with the pediatrician or primary care provider. I might even say, um, give a call to the doctor ahead of time and just to let them know your concerns. Um, and then as we talked about, a treatment team should be put into place, and often the doctor can help you with that. Um, Early intervention is really associated with the best outcomes. Someone, unfortunately, there is a high degree of chronicity for eating disorders. Some people never recover from an eating disorder and they struggle with this their whole life. It is unfortunately has the second highest death rate of any psychiatric disorder, second only to opioid abuse. Um, and but there's reason to be optimistic too. Especially if there's early intervention, it's associated. This is something that somebody can completely recover from as well. So I would say do something if you have a hunch. Um, and then yeah, that's what I would say.
Okay, so here's another question, actually, from someone from our team as well. Do you have suggestions for a young adult client who has been scared of eating fruits and vegetables for his entire life with no
Mhm.
idea why? He has celiac, so his diet is limited as it
Mm,
is.
right. Right. Yes. And so it sounds like that is somebody who needs a good um, therapist who is skilled in eating disorder work. And, you know, I mean, if I'm understanding this right, it's not necessarily a drive for thinness. It really is just sort of this fear about eating fruits and vegetables. And there are, a good therapist who has an eating disorder background can help with addressing some of those fears and maybe having the patient sort of recognize that the fears are not necessarily based in, what's at the basis for those, and are there, and certainly we know that fruits and vegetables are healthy. So what's the mismatch? But also sometimes, and this I've seen work especially with younger patients with ARFID or ARFID-like symptoms, which sounds like this young person has. Even just rewards, like, okay, if you try this one new fruit, you get to pick out a toy at the toy store or whatever. I mean, it sounds so silly and basic, but it's behavioral modification, and I've really seen it work. And then the repertoire broadens substantially with this. So getting into somebody who understands eating disorders, a therapist who understands eating disorders, is probably a really good call. Yeah. But it is tough because, you know, these patients who have celiac disease, who have other true gastrointestinal diseases, often are told to cut certain foods out. And that fear, peanut allergies, that kind of thing, that fear really can bleed over into other things. So it kind of makes sense. Yeah.
Yeah, definitely.
Mhm.
So let's say if a teen won't eat or vomits after eating, how do you get them to eat? And when is an NG tube used?
Yeah, really good question. So, um,
I'm closing my shade a drop. I'm here.
okay.
Okay.
So, um, and this is the whole process of um, that's taught in family-based treatment. But just to oversimplify it, I'll just say it really is um, tying the eating to rewards and maybe even um, I don't want to say punishments because it's not like you're punishing, but just consequences. So, for example, if somebody is on the basketball team and has basketball practice, a parent might say, like, you're not allowed to go to basketball practice unless you eat your full meal. And if you can't eat your full meal, here, we have a supplemental drink that you can have instead, but you have to get in the full calories because, my goal here as a parent is to keep you safe. And so I'm simplifying it. And sometimes it's very dramatic in their fights, but I find that if parents are consistent with the consequences and the rewards, oh, like you had a great week, yeah, you can go have a sleepover with your friend or whatever it is, um, those kinds of things, then kids understand the rules. And I've seen it work really well. With purging, the recommendation is to sit with the child or teenager or young adult for at least an hour after a meal. So those, they're not kind of secretly going off to vomit.
Okay, thank you for that. How often should somebody, let's say with anorexia or any eating disorder, be weighed? And should they know what their weight is?
Yeah. So, it depends how sick they are. I will say if I have a new patient with anorexia nervosa or restrictive eating disorder, let's say, I usually am weighing them every week to 2 weeks. And in my office, I have a special scale that doesn't show the weight. It just sends the information right to my computer. And these are actually like available to the regular public as well, but the results don't show up on the screen. And that, so we don't discuss weight in the office. And that's by design because I know that if I say the weight, that's all the teenager or adolescent or child or adult is going to be thinking of the rest of the visit. And so we just take that piece out. We tend to default to that. There are some cases where, even in strict family-based treatment, they will be very upfront about the weight. And it's almost like, yeah, this is the deal. This is where we need to get you. You're going to have to deal with it. I don't know. I think that a lot of times it's nice to just take the number out of it and then we don't have this spiraling, at least at the beginning. Yeah. So that's how I do it. I'm not sure I answered all your questions.
Well, the other part too was about an NG tube.
Oh, NG-tube, right.
Yeah.
So, you know, sometimes it is helpful, but it's pretty rare that we have to do that. So even patients who are so medically compromised, who have anorexia nervosa, let's say, who are so medically compromised that we have to put them in the hospital to stabilize them medically, which is a whole, you know, other topic we can discuss, who are those patients. But if someone's that sick that they need to be in the hospital in a medical stabilization unit for eating disorders, it's pretty rare even in those patients that we need to use an NG tube. So sometimes it's just, using all these techniques to get them to eat. And sometimes it's even, okay, I want to get out of the hospital, so I'm not gonna, or I don't want an NG tube, so I'm just gonna eat what's presented for me. So it's actually pretty rare that we have to do that, but there are some cases where it's just necessary. Like their body just needs so many calories. And when you have an eating disorder, a restrictive eating disorder, and you've had it for a while, I mentioned that, the body does all these sort of energy shifts so that it down regulates the metabolism, slows down, and all the bodily process slow down to conserve energy. But then when you start refeeding, all these processes start waking up at once and they need way more calories than their peers who didn't have a restrictive eating disorder. So they become hypermetabolic. And so sometimes patients who are 12 years old, I've have come out of the hospital needing 6,000 calories a day. And it's hard to eat 6,000 calories a day. It's hard. And so sometimes it's a necessary step. Or if somebody has really severe RFID and just won't eat, just not interested, nothing, just won't eat, sometimes they get NG, NG tubes to at least help them kind of get through that initial undernutrition. But I would say it's
Right.
pretty rare. It's not that common.
Okay. Um, how do you help parents with young children prevent um, their children from developing eating disorders?
Yeah, I mean, it's such a good question. And I would never want to um, imply that there are any foolproof ways of preventing an eating disorder. And the reasons for eating disorder, the types of eating disorders, the reasons for eating disorder development are so complicated, and every case is unique. And parents often feel so guilty when their kids have an eating disorder. They look for things that brought it on, or that they did, or um, chastise themselves for reacting certain ways or not recognizing it. And it's just that kind of guilt is just not useful. We have to really focus on what's here in front of us. Yes, we need the family to help this patient recover, but the guilt just doesn't serve us. And I assure you, there are kids who are brought up in quote unquote the perfect family that develop eating disorders. It's just sometimes out of parents' control, okay? But that all said, there are things in the research which do seem to help with establishing a good relationship with food in their children, with food and eating and all that. So I'll go over those. Um, Number one is having family dinners. And this is interesting because this is something that not only decreases the incidence of eating disorders, but also the incidence of a lot of societal ails. So, less likely there is a less of a chance that a child will develop a substance abuse problem, will develop school
Mhm.
delinquency, will
Yeah.
end up in jail, all with this food intervention. And I hear this all the time that like everybody's lives are different, and this one has volleyball practice and that one has, play, and it's just too hard and we work and I totally understand that, especially today. But it is something that I think has to be said, that this is one intervention that seems to be helpful. I would advise parents to prepare preteens for adolescent transitions. So the body weight, the body shape, um, um, changes a lot right before right before adolescence. I remember my pediatrician telling my kids that you get that um, SpongeBob square look before you sort of shoot up. So that's one thing that we expect and parents are worried about, but we that's a very normal process. And then during adolescence, their body composition changes a lot, and they're supposed to gain weight. And if you look at the growth curve, normal pediatric growth curves, there's an acceleration in weight in adolescence and in weight and height in adolescence. So they are supposed to gain weight at a rapid rate. So preparing your kids for that is always a good thing. You want to, as a parent, check your direct and indirect messages about body shape, weight, dieting. We all, um, you know, we have to think about how we are um, handling the idea, the societal pressures of the thin ideal and all that, and what that's reflected how that's reflected to our children. We really want to model behaviors that we want our children to adopt. And I would also say poke holes in media messages. So many pressures in society about thinness and the thin ideal and one body type, and where you can point out. I mean, I used to say you look at a magazine and a third of it's and but kids are today are like, what's a magazine? But anyway, the equivalent today, I guess, social media. A third is, you know, um, um, diet and wellness hacks. A third is fashion with models who are way too thin. And a third is recipes and cooking. So, I mean, there are just so many mixed messages. Another thing that I like to tell parents to tell their young kids, like, if Barbie were a real person, she would fall straight on her face. She couldn't support her proportions. So that's not normal. And I think that there is some evidence that kind of arming kids with the right tools to be skeptical about media and media messages and, whatever you want to call it, that can help kind of make them resilient and to recognize that it's not fair, these kind of pressures. Um, you want to encourage children to be active and enjoy what their bodies can do just for the sake of moving and playing and all that. So again, modeling those kinds of things are good. And I'm not just talking about going to the gym, but also like getting in the pool and swimming and or playing sports with them or whatever it is. Um, and I would say also really important, just discourage or disallow dieting. We don't need to diet. It's just it just we don't need it. It sets somebody up for problems in the future. On both ends of the spectrum of weight. So dieting is not allowed in our house, kind of a thing.
Okay, thank you. I mean, you made a good point about social media and the pressure and,
Mm.
our kids being on social media and being attracted to those
Mhm.
sites,
Mhm.
that talk about ideal weight, which is
Mhm.
skinny or not. So it it's hard to monitor where they go on social media, but
Right.
that's a really good point. There was a question about mothers who themselves have had eating disorders. Does it
Mhm.
have a higher likelihood of having a daughter with an eating disorder?
I mean, there is a genetic component. So yes, the quick answer would be yes. It's not destined, and it certainly helps if moms are recovered from their eating disorder because then the messages that they convey, either directly or indirectly, are different. And if somebody's in an eating disorder, it's hard to model sort of that good relationship with food. So I would say, yeah, put your own mask on, like in the airplanes, and treat yourself. But it is certainly not destiny. And also, mothers who've had eating disorders may be more likely to recognize some of the signs earlier. So it's definitely not a. And I just wanted to, because I'm aware of the time too. I've included some online resources about eating disorders. So if somebody is wanting to learn more, here are some good ones that, um, um, oh, great, perfect. You have them up there. So here are some good ones that you can check out as well. I think they're going to be included in the chat. And you can certainly find out more about eating disorders, treatment, what the landscape is, all of that as well. So just didn't want to run out of time before we included that.
Thank you so much. This has been so informative and a wonderful conversation and a lot to learn. Really appreciate your being here today. Thank you.
Thank you so much. It's such a pleasure.
Thank
Thank you.
you both, Dr. Shelley and Dr. Leslie Kaplan. We so appreciate this discussion here at CHIP. Hi, everyone. My name is Dr. Alicia Jean Denis, and I am the Executive Director of CHIP. And if you have enjoyed this webinar, which I know you have, I feel like we need a part two just on the social media,
Yeah,
the
right.
social media impact. There's so much there. Um, but if you have in schools, and so if you have enjoyed this webinar, please, CHIP is a nonprofit. We offer this incredible webinar for free to our community. And, your funding supports our youth programs, our direct services for youth. We have a summer camp getting ready to launch. So please continue to give to CHIP. But also, this webinar will be available online, on demand, also for free to our community on our YouTube page. And you will see all of these links in the box. And lastly, those of you who have registered, you have joined our community, we would love for you to go to our website and stay up to date so you can get information about other CHIP services. But ultimately, you will get a chance to get a post survey. And so we want your feedback. We want to hear what other types of webinars you want to see, what other types of experts you want to be in conversation. And we just want to say thank you. Thank you to all of you who showed up today during your lunch hour, your break, whatever free time you had to do this. We totally appreciate it. And thank you again for your giving and support. Thank you.
Thank you.
Bye.